Ladies and gentlemen, thank you for your patience in holding. We now have your speakers in conference. Please be aware that each of your lines is in a listen-only mode. It is now my pleasure to turn today's conference over to Chris Hund. Sir, you may begin.
Thank you so much, Brandon. Hi, good morning and good afternoon, everybody. Good evening to some of you as well. I think we've got folks from all around the world on this webinar. This is the September webinar for TeamSTEPPS. It's maintaining the gains of the TeamSTEPPS program. So this is part 3 of 3 webinars we've had with the team from the University of Washington. Part 1 talks about kind of setting the stage and assessing and understanding what's going on with TeamSTEPPS and what the tools are of TeamSTEPPS. Part 2 is really getting into implementing, and this is kind of transitioning into maintaining the gains. So hopefully we've taken you from the fundamentals at the start through implementing, through sustaining. So happy to have you all here today. My name is Chris Hund, and I'm the Director of the National Implementation of TeamSTEPPS, and I work at the American Hospital Association. Just a couple rules of engagement today. You could listen to the audio for this webinar in 2 different ways. You could listen through your phone. If you do that, please mute your computer speakers. That's a very important thing to do because otherwise you're going to get all kinds of weird feedbacky type sounds. So please do that, or you can listen just through your computer speakers. We're going to do a Q&A session at the end of the presentation, and so what we like to do is get your written questions throughout the presentation. The team of faculty will answer some of those questions that are more content-wise as they go. We'll answer any logistical questions you might have, like if you're having trouble hearing or asking something along those lines. And then anything we don't get to, or if it's a question that seems like it would be good for everybody to hear, we'll save it for the end and I'll ask the speakers. So just to ask those questions, look at that general chat box you see on the right-hand side of your screen, and that's where you can type it in. There is a helpline if you need us for anything after this call. During the call, it's obviously hard for us to answer it, but it's up on the screen, or you can email us. That's the best way to do it. We get back to you as soon as possible. So the email right there is at arcteamsteps@aha.org. All right, so not a lot of announcements today, so I want to jump right into things and get you to your presenters. As with the other 2 webinars, we have 3 phenomenal faculty members here who have been doing a lot of work with TeamSTEPPS for, I believe, 7 or 8 years now. So they really are a group of people that understand how to do this long term and how to really sustain the gains and maintain that momentum. So they'll be great for you today. We have Ross Ehrmantraut, who's the Clinical Director of Team Performance at WISH, which is at the University of Washington School of Medicine, and it's the WWAMI Institute for Simulation in Healthcare. We also have Megan Sherman, who is the Associate Director of WISH, one of the Associate Directors of WISH, and then also Farrah Leland, who's the other Associate Director of WISH. So we've got a great team for you here today, and I look forward to seeing your questions and coming back on later to ask them. So without any further ado, I'll toss it to the presenters.
Thanks, Chris. Yeah, as Chris said, I'm Ross Ehrmantraut. I'm a nurse by background and have worked in this health system for over 30 years now. Most of my bedside experience was in the burn center at Harborview Medical Center, which is part of UW Medicine. And then I went to the trauma intensive care unit. I worked there for about 9 years. So I have about 20 years of bedside experience, became critical care educator, director of clinical education, and then became the patient safety officer at Harborview back in 2005. And did that for almost 10 years before I came into this role as clinical director for team performance. And that covers all of UW Medicine. WISH is our simulation center. It's the WWAMI Institute for Simulation in Healthcare. And we've been running our Team Core program, which Farrah will tell you a little bit more about in a minute, for about almost 4 years now.
Hi everyone, I'm Megan Sherman. I am the Associate Director for Operations for WISH, the program here. I've been working in simulation for about 10 years now, and within that, we became a regional training center for TeamSTEPPS, like Chris said, about 8 years ago. My background's in education and human development, and so both Farrah and I are non-clinical, but we provide a alternative perspective for TeamSTEPPS. And we've both been very involved with Team Core and the establishment of that throughout UW Medicine.
Hi, my name's Farrah Leland. I'm the other Associate Director of WISH for Finance and Compliance. I have a law background, like Megan said, non-clinical background. I've been working with this team for about 8 years with TeamSTEPPS, and then been here at UW Medicine for about 10 years. So, UW Medicine has has about 2,400 faculty members in over 30 departments across our community, 4,700 clinical faculty across the WWAMI region, which Ross mentioned was that Washington, Wyoming, Alaska, Montana, Idaho region, 4,500 students and trainees, which includes medical students, residents, fellows, schools of nursing, pharmacy, PA, rehab therapies, and other ancillary health science schools. And we have about over 27,000 employees in our system. So the objectives of today's webinar are to really, as you heard on the last webinar, if you were on it, to identify those bright spots in the implementation process, and then how do you leverage those bright spots to keep that implementation, to sustain that. Understand the need to evaluate the process frequently and adjust that plan as needed. And then understand the importance of celebrating those short-term wins. Again, we're talking about that in the implementation in the last webinar, and being transparent with those process measures to maintain that momentum. So really looking at making sure everybody knows where you are in your implementation and what goals you've achieved. Now, Ross mentioned Team Core. So basically, about 4 years ago, we realized that our method of train people and what one of our colleagues likes to call spray and pray, just train people and hope that it sticks, was not going to help us change and sustain the culture here in UW Medicine. So we developed a what we call Team Core, which is a team collaboration for organizational excellence. And the goal of that was to use TeamSTEPPS as the education and training piece of Team Core, but then also add these other complementary things like coaching and mentoring, assessment and outcomes, and then some other initiatives that really integrate nicely with TeamSTEPPS around patients are first, just culture, leadership, all of those. So you can kind of see that triangle, how we built that, the idea of Team Core. And if you've looked at any of the TeamSTEPPS materials, you probably recognize this slide. So just there's really 3 phases to shift towards that culture of safety. We took that slide a little bit further in a little more detail and customized it for our system. And you can see here we took phase 1 and did that pre-training and assessment. And I'm not going to read the whole slide, but you can just see how we broke it down into these 3 phases. Really thinking of how best to integrate UW Medicine's Team Core into our system.
So as we move into how we try to systematically approach any kind of implementation program, I just want to show this review slide. If you were on the webinar last month, we talked about our leading change models, and we really got into some detail on the switch model by Dan and Chip Heath. And if you weren't in the webinar last month, I would encourage you to look this model up and maybe even consider reading the book. But this is how we work through our process, and I don't want to go over this in any detail. It's just more of a reminder. But you know, we're going to get into directing the rider, motivating that elephant, what's in it for everybody. We all know that TeamSTEPPS is the right thing to do, and it is about patient safety. But really in healthcare, people want to know more than that. They want to know what's in it for them. And then how do we shape the path? How do we make the right thing the easy thing to do? So, and again, from the TeamSTEPPS curriculum, the 8 steps of change from Cotter, You know, he talked about we're already beyond unfreezing the status quo, finding that sense of urgency, building the guiding team. Hopefully you have a change team in place, or this should, if not, that should be one of your first things. Getting understanding and buy-in, and again, we like to use the term ownership, where the front line gets to own this process. TeamSTEPPS is going to happen, but they get to own how it's going to happen. And getting into the second phase there, we start introducing new practices. And as Farrah said in the objectives, short-term wins. We're going to start empowering people to speak up, and we're going to give you some examples in our system how we've done this. And then finally, it's just got to be relentless. You can't let up. And we'll show you some results from a couple of areas in our health system, just related to team perception questionnaire responses, and how that culture change is starting to happen in some of these areas. One of the things we learned early on is, and one thing I didn't mention is, I've been also doing TeamSTEPPS for about eight or 9 years now too. I told you I've been in this role for about 4 years, but I was doing TeamSTEPPS before that, my patient safety role. But what we do is we go out and teach people all of the tools of TeamSTEPPS, and we spend how many ever hours doing that, and then we basically say go forth and prosper, back to that spray and pray model. What we've done is realize that that's probably not the most effective way to do it, and we've broken down the tools by 100, 200, and 300 level skills and try to work systematically through those. And that's the list. Again, we talked about that last month as well as the first webinar. So I want to get into our example. And we mentioned surgical services last month in the change, leading change model or webinar. But we want to go through this with a little bit more detail today and walk through some of these steps. And again, in one of our hospitals in our health system, they have 25 ORs with 11 different services that function in those ORs. They have the PACU, the central processing, or that's what they call it in that hospital. You guys might know it as the sterile processing department, the pre-anesthesia clinic, and the ambulatory surgery pre-op area. Again, a huge amount of people, over 400 people involved in this, including surgeons, CRNAs, anesthesiologists, etc. So we're going to kind of systematically walk through the 10 steps of implementation planning here. And there's first 4 things. Is really what the first thing we did was create that change team. And this is really important. And sometimes when I talk to people around the country, they have an overarching change team. They call it overarching change team at maybe the quality and safety department level that's overseeing all these TeamSTEPPS programs. And that's great. You got to have that. But within the department, they have to have their own change team, and that's where ownership comes in. And so our change team in surgical services includes somebody from our central processing, and it has 4 surgeons on it. It has 3 nurses from the OR, 2 from the PACU. We have a radiology technologist. We have housekeeping represented on that change team. So you can see it's a very diverse group. And they sat down and they developed what we call the destination postcard. Oh, here's the list of the people on the team. Well, I left out the CRNAs there. But here's what they came up with. There is a common disconnect, their destination postcard. And again, this comes from the switch model for directing the writer. You got to give somebody some clear idea where you want to go. And lots of times, we'll get into resistance in a few minutes, but lots of times that's what happens. People don't even know where we're going. We get this top-down thing and say, okay, today we're going to do this, but nobody really gets the rationale for that. So this change team came up with this problem statement, and this was specific to the OR. Again, going back to that change team, it was interprofessional, multiple different areas. They decided to begin with, they were going to start small and go right into the operating room. There is a common disconnect in developing a shared mental model for all cases throughout the day. And their destination postcard was implement a morning brief in every operating room to plan for the entire day in each room. So that was kind of a big ask. Every OR, 25 ORs every morning. So they thought about that. They got some surgeons that agreed to do it. They started to develop a plan for testing the effectiveness of your TeamSTEPPS intervention, of their TeamSTEPPS intervention. So they developed a template and a tool. And what they did is a small tested change. They had a brief pilot, not a short pilot like a morning brief pilot. They had 3 surgeons that were willing to implement the morning brief in their OR starting at 7:10 in the morning. And this brief was designed, it's not the timeout, the patient's not in the room yet. This brief was designed to plan for the whole day in that room with the surgical techs, the RN, the circulator, the anesthesiologist or CRNA, and the surgeon who would be leading the brief. They did this pilot in September of 2016, so a year ago now. They tested the form that they designed, that was designed by the change team, and they immediately started tracking these things. They started looking for measures. How long did it take to do the brief? Were they delaying first case start times? Because in many hospitals, first case start times is a big thing people watch. You know, if you start getting behind, that's money. How often it was done, and who attended, and finally, did they get any significant information from these briefs? Now, it was pretty interesting because right away it was an orthopedic doc, a general surgeon, and a hand plastic surgeon that did this. But quickly, it expanded to 16 other general surgeons that saw what was going on and decided they wanted to do it too. So right away, or about a month and a half later, that increased from 3 to 19 different surgeons doing the morning briefs. So we were starting to get some momentum early on. Now here's the good one. This is what the brief template started out looking like. And they spent hours on this, and we sat down and we worked it through and added stuff and removed stuff, and this is before they even trialed it. And within the first week, they were coming back going, okay, this is too long. We can't do this. This is painful. The brief was taking 8 or 9 minutes at 7:10 in the morning. If you're familiar with the OR, that's not a good thing. And people were not going to do it anymore. So they sat back down, went back to the drawing table, and came up with this. This is the form they use today. Although, I'm sorry, I don't have the most updated one on there. That last column should say nursing/surg tech review. But the surgeon they start it, they say things on their agenda, anesthesia goes through, and then nursing/surg techs will say their thing. And you can see up in the box, in the top box there, gives them a little idea, things to think about for this brief. So now they went from that very long brief tool to this tool, which they use every day in every OR now. So that was kind of doing that PDFA, and what they found in the pilot is 91% of the briefs provided new information that people didn't know. And this could have been things along the lines of positioning for a later patient, which could be, it's not a huge time saver, but it does make people more organized, to the point of like an implant that they needed for maybe a third case that they had to get from another hospital because it wasn't, or the vendor, because it wasn't in-house. So they started looking at this and they're going, wow, 91% of the time it's making a difference later in the day. So it got, like I said, it got a lot of momentum early on. People were pretty excited about it. And then we started developing, okay, how do we roll this out throughout the entire OR, all 25 rooms, all 11 services. I'm not even sure how many surgeons, but quite a few. So we're going to develop our implementation plan, and here's what they did. Now, I didn't tell you when this change team, and they call themselves the Oversight Committee, started. It was in July of 2015. So that was a year and a couple months even before they started that pilot brief. What they did right away that first year is did the team perception questionnaire and got a pretty good return rate from all professions. They got about an 80% return rate on this. It was an online survey that we put in our Catalyst. And they looked at that and they found some low-hanging fruit. One was the basic communication, closed-loop communication things that they could implement without a whole lot of, work. But they also realized that people were frustrated. From this survey, they were frustrated about their daily organization as the day went on. And so that's where they came up with the idea of looking at a brief. In 2015, they did a safety summit, hour-and-a-half session, where everybody, it's a mandatory attendance. They all showed up, and that's when they started introducing the thought, okay, TeamSTEPPS is coming to surgical services. Start thinking about it. In 2016, they did it again, and that's when the pilot teams shared their thoughts on their experience with the brief. So it worked out pretty well. 15 was the introduction to it. In 2016, we had started the briefs, and those groups, nurses, surge techs, anesthesiologists, surgeons, all stood up and talked about their experience with the briefs, what they liked about it, talked about the challenges too, and how they addressed the challenges. And then we developed this innovative training plan. I've been doing this a long time, and this was probably the most innovative, but very effective. Again, closing an OR is money for any hospital in the world, and administration just wasn't willing to close OR for one mass training. So we ended up developing a plan where we could tap into the meetings they already had in place. So for example, every Wednesday morning at 7 a.m., OR staff has an in-service from 7 to 8 a.m. Well, we took the TeamSTEPPS training and we broke it into two sessions. We had TeamSTEPPS first session, TeamSTEPPS second session, and we went through the tools on session 1, and you can see the Legos in there. That's one of the exercises we do in that picture. And then in session 2, we went into more of the 300 level tools and then talked about the brief implementation, getting feedback from everybody. This took 5 months, 17 different trainings to get everybody completed, surgeons, all groups, and had a lot of good feedback, but as you can imagine, a lot of pushback too. You know, and we don't have time to do the brief and et cetera. But we worked through, and the chief of surgery at that summit in 2016, which was in October, he said as 1st of January, we are introducing briefs throughout the entire OR. Everybody is going to be required to do them. So that was the goal. So they started those in January. Then we had to develop, how are we going to continue this? How are we going to keep people on board? How are we going to keep people wanting to do this? And how do we make sure people know what's going on? Well, right away, we started tapping into those bright spots. So we got the pilot, and we had the people from the pilot talking about what worked for them. But we needed more information. When you go to Surgical Council, they're looking at data. They're looking at your dashboard and whatnot. Well, we were able to show that it did not delay the first case at all. Once or twice, but definitely there was no trend that first cases were being delayed because of this new morning brief. They're noticing the 91% of changes were noticed right away in the pilot, and once it was implemented throughout the whole OR, 70% of the time they were finding new information. And the information goes on and on and on. I have a slide that I'll show you. Most of the responses from people in a follow-up survey were positive. We had anecdotal stories. One of my favorite stories, I have a picture of him in here a little later, is one of our ortho guys. When we did the training, he was very verbal about this not being a good thing, and it was going to slow him down, and Ross is coming in and making us do stuff, and now he's one of our biggest champions and has written many emails about how it's been effective. Sterile processing has been better informed, so when they find out in the brief in the morning, they might need an implant, or they might need a certain amount of trays during that day. There's some communication going on with the sterile processing department, which is like most hospitals, it's not located right next to the OR, it sits a ways away. Staff got to present at 2 national conferences on their results. And then every Wednesday at that staff in-service I mentioned about, they share these results. They talk about how often the brief is being done, which is really about 70, it went to 70% of the time it was being done, to now it's over 85%. So it's 9 months. We're not at 100%, but we're pretty happy with that so far. Surgical Council gets updated monthly. It's discussed in the surgery grand rounds and anesthesia grand rounds, and they present at the Patient Safety Committee. And this box in the bottom in the blue font, we tend to want to focus on why something won't work. And in the switch model, it talks about the Jerry Sternin story, and we get a lot of what Jerry Sternin would call TBU, true but useless information, which is we're told why something won't work, and you're right, you know, we can't change that. We can't change our first case start time or whatever, but can we work around to make sure it works? So let's focus on how things will work, because everybody's going to give you reasons why something won't work. You have to spend the energy on why they will work. Just a side note, I probably shouldn't throw my wife under the bus here, but she happens to work in this operating room. And early on, she came home one night, and she's like, oh, I can't believe we're already doing this and this, and now they're going to make us do a brief in the OR every single morning at 7:10 a.m. And I'm like, you know, that's what I do for a living, right? And she's, you know, so finally I said to her, it doesn't work as well at home as it does at work, but I said to her, you know, well, you've told me all the reasons it won't work, but if it works, is it valuable? She goes, well, yeah, I think it'd be valuable. Well, so then let's figure out how we can make it work. And again, it's my wife, so I'm probably a little biased, but she got on board and she pushed it forward, and now she gets mad when the brief isn't being done in the OR. And in fact, she's pretty proud. She just brought home a big certificate because she got the Patient Safety Award for all the surgical services last month. So anyway, you guys don't care about that. But we did have challenges, and we're still addressing those. There's constantly new hires coming in, but you know what's cool about this is it's the briefs occurring in the OR. People are pretty happy with it. You don't have to spend a lot of energy on teaching the new hire TeamSTEPPS tools or that TeamSTEPPS tool when they're seeing it done every single morning in the OR. Now the closed loop communication and stuff, you have to model that, and that's one of the things they've done from day one, and they continue to push forward. They're moving into other tools like CUS and things like that. We need to acknowledge our resistors, because sometimes they do have a good idea. Sometimes they have a good reason why something won't work. And a big part of it was, we can't do this at 7:10. It was hard to get the team together. Some of the surgeons are on rounds, and et cetera. There are multiple things going on. So some of the things you do is, okay, surgeons on rounds, is there any way we can work this around? Well, then we set it up so the surgeons could call in. They didn't necessarily have to be physically in the room for the brief, but they had to call in. And it can't be their resident. It had to be the surgeon running this, or the fellow. We had concern about competing priorities, just like every other institution. You know, we're a Studer hospital or a system, and all these different things going on. You cannot let this be a top-down thing. You have to let them own the process. And those people on the change team, they went out and talked to staff, not the director of surgical services, not the nurse manager. They went in, the change team members went in and talked to people about this. Radiology technologists talked to her peers, and they try to get involved in any cases that radiology is involved in. And in that hospital, radiology, they have a radiology section in the OR because they do so much trauma. Again, concerns about delaying cases. Some of the docs, although we haven't been able to show this on hard statistics, but some of the docs believe their turnover times are actually better than they were. They're not getting any slower, but we haven't seen that move quite yet, where we can show with hard data that their turnover time is getting faster. And then the timing of the brief was difficult. So about 4 months ago, or 3 months ago now, they decided to change the time of the brief to 7 a.m. Now, you think about that, most nurses and surg techs, they start their day at 7 a.m. Well, what they did is they actually were able to work with the union and change the start time for surgery, for the surgery staff, to 6:45 a.m. So now they start 15 minutes earlier and they get off 15 minutes earlier about that. So again, we showed this resistant audit last month, and it's one of the things I think you always have to keep in mind, because sometimes when you're one of those ones leading these changes, you get frustrated with people's responses, and just they make excuses, they delay, and sometimes we misread those things as they just don't care. They have a poor attitude, they're incompetent. But really, if we give them clear instructions on where we want them to go, and maybe some rationale, for example, that destination postcard this change team put together, they kept going back to that. This is why we're doing it. We're not just doing this to make more work. We're doing it to be more efficient. Obsessive questioning, we look at them as they're skeptic, which is skepticism's okay at times. But it might be just because they're just overloaded with the pace of change, and so we have to make sure we make it easier. And that's what that template did. It went from very laborious to very streamlined, and they like it now, and they actually use it as a handoff tool. When the surge tech goes on break or the circulator goes on break, they use that tool to do the handoff. And so, you know, you work down here, errors, just lack of engagement. And finally, there's just the ones that just don't want to do anything, derailing or acting out, and the resistance, the change themselves. And these people need to be coached and reminded that this is something that's making us more efficient and move forward. And sometimes people will leave if they don't like it, but eventually in healthcare, everybody's going to be doing the same thing. So those people that just don't want that change, they're not going to be in good shape. So then finally, moving through the TeamSTEPPS from the curriculum, we're going to develop our TeamSTEPPS implementation timeline, and we reviewed the plan with key stakeholders as we develop this plan. So our ongoing evaluation and next steps, our change team continues to meet monthly. And I think this is a huge thing. What happens is you get the implementation going, and then everybody quits. You think, okay, we got it going, and we're fine now. So good work, everybody. Let's move on to the next project. This change team still meets every month for 1 hour. In fact, we're working with one group now that is different than this one, that their change team meeting is at 6:15 in the morning because they want to start it before their surgery. This is a different hospital in our system. So you have to work around their times. It can't be around your time. You have to work around their times. And so right now the briefs are occurring, like I said, at 80% of the time. And we're continuing to focus on what's working, how come it's working so well, and working on how do we make sure that keeps evolving so we can get to 100% of the time. As I mentioned, we've changed the start times to 7 a.m. We're looking at additional measures of success. We're hoping to be able to measure things like are we cutting down on wasted equipment because of the brief, or packs not getting opened that somebody thought we were going to use, but the brief prevented them from doing that. So things along that line. Our follow-up TPQ with that group is scheduled to go next month, Team Perception Questionnaire. And then we're setting up simulations of interoperative emergencies with the Chief of Anesthesia and the Chief of Surgery, as well as the nurse manager there to get insight to simulations and mock codes and other emergencies going in there. And the goal will be not only the clinical aspect of that, but the teamwork and TeamSTEPPS part of it. Finally, I'm going to hand this over to Megan, who will talk a little bit about, give you another example within our health system in a different hospital in a whole different area.
Yeah, and so like Ross had mentioned, working with the OR, that's kind of an ongoing project. The team core model has been working with a childbirth center here in the UW system. It was one of our first projects that we worked with the team core, and it kind of speaks to the essence of it's never done. You're never done, and it's an ongoing evolving or ongoing sustainment with these groups. And so just giving kind of an overview, this childbirth center that we've been working with, when we first started with them, first steps that we took were developing that change team, really defining the problem or identifying what our destination postcard would be. For them, it was specifically starting with brief huddles, implementing that closed-loop communication and cuts, but really a focus on starting a brief. And we took some baseline assessments, which we'll go over here in a second. But it's only natural that enthusiasm wanes over time. And Ross talked a little bit about this. Kind of that push of training, and once you're done with training, everybody says, okay, we're done now, we're just going to do it. And there's a tendency for that enthusiasm to kind of fall off over time. And so one of the things that's really important that we've learned with this group that we've been working with for now about 3-4 years is really how do you sustain that momentum? How do you build it up, and how do you revitalize it when it starts to kind of taper off? And so what we've been doing with this group particularly is continuing those change team meetings. We have monthly meetings scheduled out. Ross and I have been working with this group most closely. We're there to support them as much as they need, but really providing that ownership to them. yet having those scheduled change team meetings, you kind of have that ongoing push monthly to, okay, we're going to keep this going and keep this going. We incorporated TeamSTEPPS tools into the evaluation of emergency bleeding simulations. Working here in our sim center, we've been able to kind of help them run OB hemorrhage drills, and building TeamSTEPPS concepts and tools into that, making an expectation of the evaluation process and performance checklist has been really helpful, kind of keep it at the forefront, that it's not an add-on, it's just something that you're doing as part of your regular practice. Holding quarterly meetings. Oftentimes you have a group like this where you have new staff that comes on board, or you have turnover and you need to train folks. They may be coming from other units. And so holding periodic refresher trainings or holding additional trainings for new staff. We have one coming up next month, beginning of next month, that's just kind of this quarterly add-on. And then I think somebody mentioned it on the chat, but acknowledging your performers. Everybody likes to feel appreciated, and so by making sure that you're acknowledging the folks who are really taking this to heart and really doing it. We had, in this group in particular, there was an email that went to the executive director and the CNO of the hospital commenting on how a junior nurse was able to, or felt comfortable leading actual hemorrhage that happened in the childbirth center because she had gone through this training. And so by acknowledging this individual at kind of the highest levels, she felt that she was doing a great job, and others in the system were seeing that it was working. And so really kind of acknowledging and giving credit where credit's due is always a great idea. So we mentioned kind of our baseline assessment and then these follow-up assessments. We have completed, the blue line you'll see is the pre-training, that's our baseline. Post-training was taken about 8 months after that initial push for training. And we're going to be completing another follow-up TPQ here in the next few months, I believe. But it's just a couple things to note. You'll see a general increase, I think, trending for all of our TeamSTEPPS principles. But a few I just want to point out would be the, for team function, it was that the team was clearly articulating goals. And they felt that they were able to better do that once they've had this training.
So can I just add?
Yeah, please.
So one of the things this group came up with was a morning brief. They would do it at 8 in the morning after everybody got settled. It included the OB doc, the nurse midwife, any nurse that it could attend. It was at least a charge nurse, but any nurse that could attend. They got the neonatologist, and then they got the anesthesiologist. They had 6 or 7 people, and the nurse manager would attend this brief every morning. And that's how they kind of got everybody on the same page for the day, looking at staffing, looking at some of the patients. It got so popular that the night shift insisted that they wanted to do it too. So now they do it at 8 a.m. and 8 p.m. every single day. So I think that's probably why you see that number go up.
Yeah, and general trends also, feedback between team members was delivered in a way that promotes positive interactions and future changes. When we came into this group, there wasn't a lot of collaboration or interaction. And so one of the reasons this the pre and post TPQ was so beneficial is that you can actually see a growth in these areas. And by celebrating those changes and periodically kind of doing check-ins and how are we doing, it really helps move that along and help people remind them that this is actually something that's making real change on their unit. Another area that we saw great improvement was the situation monitoring, both for the team members monitoring each other's performance, as well as the team members that share information regarding complications, and continuously scanning the environment for things that might impact important information. And then finally with communication, just again a general uptrend on a lot of these things. Team members, that they seek information from all sources, that they're working together, and that they're communicating appropriately. These are just things that the change team shared, that we presented this information back to the change team, and the change team then shared this information out with the rest of the unit. And making sure that everybody's involved in the process has been very beneficial for this group.
So, yeah, so that was kind of more of a follow-up related to that childbirth center. You know, I guess maybe we didn't really think about this ahead of time, but their destination postcard was to I can't remember exactly what it said, but basically they wanted everybody to feel comfortable speaking up in the cases of patient safety. And so we talked about the 100, 200, 300 level skills, and you might have noticed that the 300 level skills, that's where CUS set, because we feel like CUS is really a culture change. But they really wanted to get moving on that faster than slower. And so that's why we encourage them to do that morning brief, because if you want to get CUS, you can't just give people the tool, again, third time we said this, spray and pray. You got to empower them to do it. And the brief was an opportunity. At the end of the brief every morning, whoever was leading that, they would say, okay, they'd look at people on the team and say, if you have a concern about what's going on, I want you to cuss at me, basically. I mean, I'm simplifying that a little bit, but you get the idea. So as we work with these teams, we think there are some key factors in planning for the implementation and keeping it going. And every single group we work with, and if you've been to our Master Trainer course, we don't let you walk out of this room without doing this, a 30, 60, 90-day plan. Again, going back to what Don Berwick says, some is not a number, soon is not a time. And if everybody just says, yeah, this is a great idea, let's do it, then nothing happens. So we develop a 30, 60, 90-day plan with our change teams. And that continues to evolve. And eventually, you get through that 90 days, and now you keep building on it and starting it over. And things change as you go, but you keep referring back to it. We're working with a clinic that's been a couple years now, and they were having a little trouble. So we sat down a couple weeks ago and, okay, here we go on 30, 60, 90-day plan. How are we going to keep moving forward here? And so think about that. It doesn't need to be rocket science or anything, but have a good plan in place using that. Our job one is develop a destination postcard. Where do you want to be? And then work backwards from there. Start small, 1 to 2 tools at a time. Think about that switch model, working through each one of those. Okay, directing the writer, that's the easy part of the switch model. That's the training. That's getting people on board with knowing where the goal is, where we want to go. And then we do the training. And we do that really well in healthcare. What we don't do so well in healthcare is tapping into what's the motivation for everybody. And again, patient safety is a big motivator, but you have to have more than just that. They want to know what's in it for us. The surgeons, what's in it for us to do this morning brief? Same thing with the anesthesiologist. What's in it for the neonatologist to show up to this 8 a.m. brief every single morning? You have to find out, because it's going to be different depending on who the person is. I can tell you that the chief financial officer has a way different thing that motivates them than the frontline nurse. It was interesting. We worked with one group, and their administration wanted to increase throughput through the emergency department, which seems, it's a good idea, right? It sounds great. But then you go to the frontline staff and go, here's your destination postcard. We're going to improve throughput through our emergency department. And the nurses look at it and you go, well, that just means I got to work harder. So you have to figure out, well, what is it that's going to motivate them that will help throughput, but you look at it in a different way. So working with, that's where the frontline staff has to own the process. Consider reframing. A lot of you probably tried to roll things out, and it might have been TeamSTEPPS in the past that didn't go so well. Well, maybe you have to start presenting it in a different manner. Okay, we're not going to roll out all of TeamSTEPPS. We're going to start with closed loop communication. Let's just get that on board, because here's a story that happened in our health system. Tell them the story and say, this is where closed loop communication might have made a change. So now you reframe how you say things. Again, looking at those those change models that we talked about, and we can't say this enough. You have to let the frontline staff own this process. Now, we don't just go in there and sit in a meeting and take notes. We guide them. Say, Megan, Farrah, and myself, we guide them as we go through, and we have other people on our team as well, because we know what works and what doesn't work. So if they're going down a path that doesn't look good, we're going, okay, let's back up a little bit. But at the same time, we don't dictate. So a couple of key factors, and this is where sustaining dies fast, is when you declare victory too soon. I mean, our surgical services, and all these processes are slow. The Childbirth Center, it's been almost 4 years now. but you're seeing the culture change happen. I think you got to plan on 5 years to really see that culture change happen. You can declare some victories. You can say, well, that battle of getting those briefs started, I think we've done a great job with that. But we're not done yet. We have a lot more things to work on in that surgical services, as well as working across the other professions in that area. You have to continue to meet. You can't just do the training, see things are going well, and then stop meeting. And really, we've not had any pushback for the most part on having a 1-hour meeting once a month. Do we get everybody at every meeting? No, but you get enough people to keep the momentum going. You know, we hold ongoing trainings for new hires. Again, we work around their time, not our time. So we do this on weekends, we do them on evenings, we do it when they need to. And they're short, you know, they can be anywhere from 2 hours or 90 minutes to 4 hours, depending on who we're talking to and what the process is. And then eventually the goal would be, this is just the way we do business, and you won't need this training anymore. People will show up, you know, they're getting into the schools now, so hopefully we won't need to have people doing this anymore eventually. Probably not in my career, but maybe some of yours. Start small. Don't throw all those tools in at once. And I think we see a lot of that. Oh yeah, they trained us on all these tools, and then they expect us to go out and use them. It doesn't really work that way. We like to get those early successes. Look for that low-hanging fruit on the team perception questionnaire. There's some low-hanging fruit, and I can pretty much tell you everybody's going to have some of those same ones. Closed-loop communication can take care of a lot of those, or several of those questions on the team perception questionnaire. SBAR can help with a couple of those. Right away, you can get some quick successes, and you celebrate those. You have to be systematic to get these early successes. So this is our information. We want to leave time for questions. I know that was a lot of information, and I guess at this point, there's some, I'm going to just address this one question that Farrah pointed out to me about the team perception questionnaire. We use that for every single group we work with. It's a requirement for every group that we go in and see. And we do that very early on before any kind of action has been taken. We meet with the change team. It's usually 3 to 4 months after our first meeting with the change team. Talk about it, go over the team perception questionnaire, what the questions are. It's a customizable tool, and it's in the TeamSTEPPS curriculum. If you don't know that, you can pull it right off the AHRQ website. We put it into a Catalyst survey, so it's electronic. And then we send out, we put together a draft email, and then the change team members send it out to their group. So the surgeons that were representing our change team, they sent it out to surgeons. The nurses, the nurses on the team sent it out to the staff nurses. It comes from them. It doesn't come from us. It doesn't come from the administrator. It comes from the staff. And the change team goes out and talks it up a little bit. Therefore, we get a huge response rate. Probably the worst response rate I've seen is 70%. But that's because they're saying, not only here it is, but we're going to talk about it, and we're going to review it with everybody in this department. They're going to see the results from this team perception questionnaire. So it helps focus, one, your training, your destination postcard or getting things moving forward. But it also is a great tool to follow up with. Some people customize it. You know, we didn't show the leadership one on the Childbirth Center because they customized that significantly and it added a bunch of questions to it. But those results all got better too. So that's one of the things you talk about with the change team. We find it very valuable in our system. I would encourage you to look at it and consider it because it is a way to show that over time teamwork has improved. The culture of safety survey is great, but this digs down even deeper, specific to TeamSTEPPS concepts. So I know there are a couple questions related to that, so let me know or let us know if you have any other. Otherwise, I have nothing else to say right now, so we're open for questions.
Thanks, Ross. This is Chris. While we're waiting to see if any other questions come in, I was thinking about this whole 3-webinar series as all of yours journey with TeamSTEPPS. And so, you know, maybe a nice summation kind of questions would be, you know, what is the one thing that as a team you're proudest of doing within your TeamSTEPPS work at the University of Washington? And then what's the one thing that, looking back, you would have said, that's the turning point, we should have done something differently, it would have made things easier for us in the future?
So, I mean, as far as proud of what we've done, I think probably the coolest thing that we see is when a department has this transformation going. And there are departments in our health system, and I don't want to call people out, that were very, very toxic. There's the word, yeah. And to see the transformation that was made in some of these departments, are we completely done with them? No. But to have people, you know, for example, the ortho surgeon that I gave that example where he was so, I would say he was angry in the training when we were talking about the brief, and that might be a nice word to use for it. I mean, I was ready to go find a job at McDonald's after that meeting. And now he's like, oh my God, this is making my day so much smoother. And I should have pointed out the picture I had of him doing his brief with his team, but it was in one of those slides. So, I mean, just hearing those kind of feedback, the example Megan gave you about the childbirth center, and a new nurse took over the leadership role in a postpartum hemorrhage, because we teach people leaders can't be doers, but they have to have that situational awareness, and seeing these unsolicited emails related to that. Our burn center was just a classic example of, and I told you I started my career there, and it was pretty amazing to see the transition there. In fact, they went 8 quarters in a row where they have the top patient satisfaction scores in our entire health system. Now, I don't think we can take credit for all of that, but the chief of the burn center, she'll say that too. We can't say TeamSTEPPS is responsible for all of that, but it played a huge role in it. So just seeing those, not only the data, but the actual anecdotal responses you get from people is huge. I think as far as, wow, that didn't work so well, we learned a lot over the years, you know, where you walked out of a room with your tail between your legs because you're like, oh, that didn't go well. And it's not all roses, right? You go into these meetings sometimes and you have this great plan and people are not interested. We've learned a couple things on that. One, people have to be ready for it. It can't be the CEO of the hospital calling you and saying, hey, you need to go into this department because they're not doing well. That's okay to a point, but that department has to say, yeah, we agree. We need some help here. And I know there's the pre-assessment survey on the website that you can use to kind of find out if your department is ready. Unfortunately, sometimes I think the people that fill those out are the CEO or the CNO, not necessarily the people that are actually in that department. So you got to be careful on that. We also learn, start small, don't overwhelm people, give them 1 or 2 tools. And again, we learned that the hard way. So I feel like our team has done a good job of figuring out the systematic approach to this. And some groups we can move a lot faster with than others, and you just have to accept that. You move at their pace, not our pace. Yeah. Anything else, you guys?
I think just one more thing to tack onto that, in our experience, is that concept again of ownership. Team core, the way it's structured, we can mentor till we're blue in the face, but if people aren't willing to take ownership of it, or we're not giving ownership of it or the opportunities to own it, it's doomed from the start. You really have to find those people who have that fire in the belly, really wanting to make a change. And they're hard to find, but once you do, it makes the job so much easier to really implement it and sustain it long term.
So one of the questions related to track system changes over time. We do follow all the surveys, so employment engagement, culture of safety, of course, then the TPQ. The employee engagement survey, we've had unsolicited comments on those saying TeamSTEPPS has made a huge difference in their department. I'm summarizing a little bit, but that's basically the overview of that. And then each department, we go in and we find out what things they're already measuring. And we don't invent new measures, except for the team perception questionnaire. We don't invent new measures. We work on them on something they're already doing and identifying tools that might be specific to whatever measure they're looking at. So, for example, one of the clinics we're working with, they're trying to decrease wait times. And that's something they're already measuring. So how do we get those tools going? What are the holdups on wait times, and how do we move forward on that? So I'll be transparent here. We haven't had a ton of measures related to actual patient outcomes. We're still looking at that, trying to get those, but a lot of ours are cultural outcomes. How are we changing the way people think?
Well, thank you very much for giving us 3 wonderful presentations. You could really get the sense of what kind of journey you guys are on and how you're, been moving forward. So thank you very much for sharing that with us, and thanks to everybody for listening and for chatting in your questions. I think we've answered most of them. We're almost at the top of the hour, so I wanted to stop here, but if there's something that we haven't gotten to, we'll make sure to get it answered for you. So, yes, Ross.
Just answer that one from Randy real quick.
Of course.
So we have rolled it out, and you're right, OR, ED, and OB are kind of the ones everybody started in. But our burn center has this ICU and acute care floor. We've rolled it out in tons of clinics. Well, not tons, a lot of clinics. We've rolled it out in a med-surg unit. We've done interprofessional rounding in a telemetry unit. So yeah, we've had experience in rolling it out in all different areas. And you're feel free to email us, Randy, if you have some specific questions about that. Sorry, Chris.
No, that's okay. Thanks for answering that. So thank you all for listening to the webinar today and for chatting in your questions. And thanks to Farrah, Megan, and Ross for being with us for the past 3 months on the TeamSTEPPS monthly webinars.
Yeah, thanks for having us.
Thank you.
Yeah, thank you.
Thank you, ladies and gentlemen. This concludes today's conference. You may now disconnect your lines.